Welcome back to the third session about individualized antiplatelet therapy monitoring. So we have one speaker, Nikita Lomakin, and also then later on in the discussion, Daniel Aradi. Maybe you can just shortly introduce yourself, Dr. Lomakin.
Yes, hello, colleagues. It's a great pleasure for me to be here. I'm very sorry for my voice. I'm a little bit ill. So I'm head cardiologist of the Presidential Affairs Department in Russia, and I'm head of cardiology division in Central Clinical Hospital in Moscow. So can I start my presentation, Klaus?
Maybe a short introduction just from Daniel Aradi that everybody knows who is in the panel, and then we can start, of course, immediately with the presentation.
Yes. So hello, everyone. It is a great pleasure for me to attend this session. I'm Daniel Aradi. I'm working in Hungary. I'm an interventional cardiologist, associate professor in the Budapest Heart Institute of the Semmelweis University. And then my interest is antiplatelet therapy and individualization. I'm looking forward greatly for the session and have the discussions later.
Yeah, thanks a lot. So, Dr. Lomakin, the floor is yours.
Dr. Klaus, just one interruption before Dr. Lomakin starts. For those new people who have joined just now only for this session, want to let them know that after Dr. Lomakin's presentation, we will do a live poll, get some feedback from the audience, and based on that poll and on the presentation, we will have the discussions that will follow with the expert panel. So that's it.
Yeah.
Over to you, Dr. Lomakin.
Before I start, I just want to say that it's a great pleasure to me to be here together with Daniel, because Daniel visited us a few times several years ago and made his presentations during our conferences. Nice to see you, Daniel. So I want to start my presentation from this slide and to say that today we have different antiplatelet agents which are used in a variety of conditions in cardiovascular patients, in peripheral arterial disease patients, in cerebral artery disease patients, and in most colorful way, it is presented in, the evolution of antiplatelet therapy presented in cardiovascular and acute coronary syndrome patients. As you could see here, starting from no therapy at all at the beginning, then the aspirin monotherapy in cardiovascular and ACS patients at the end of 80s, and then the era of dual antiplatelet therapy. And as you could see here, each new drug is more potent and more effective than the previous one. And what we know today about these drugs is that there is platelet function variability. I'm sorry. Yes, platelet function variability between the patients. So most of the patients have adequate response to antiplatelet therapy, but some are over or low responders. I don't think that it is needed during this presentation to discuss the reasons or the mechanism of this high on-treatment platelet reactivity. I just want to show some of the reasons which is recognized as the most important. It's age, it's obesity, it's different drug interactions, different comorbid conditions, and of course, pharmacogenetic factors. Also, I want to show you the results which were published just recently, a few months ago, from our group. This is the results of the 750 patient trial, and it was shown, according to the multivariate analysis, that there are also some other conditions which correlate with high on treatment platelet reactivity. It's myocardial type 2 infarction, and it's chronic kidney disease. So how we could recognize inadequate response on dual antiplatelet therapy? We could phenotype our patients by using platelet function testing, and I will talk about this today. And we also could use pharmacogenetic approaches. Pharmacokinetic and pharmacodynamic data support the diminished clopidogrel response in so-called love carriers. And on the right hand of the slide, you could see the large meta-analysis of ACS patients after PCI, and it was demonstrated the increased risk of cardiac events in CYP2 C19 love carriers patients treated with clopidogrel. I'm sorry. This is the results of one of our trials, which were published in Cardiology and Cardio several years ago, together with our Korean colleagues, and we showed that the problem of pharmacogenetic polymorphism is not a problem only of clopidogrel, but also of other antiplatelet agents. So here you could see patients after ACS who received prasugrel, and you see that there is an association between the increased level of platelet function according to the Verify Now platelet function system in those patients who were carriers of polymorphic markers of PE450. Also, one more study, which the results was presented 1.5 years ago on the EEC Congress of Cardiology. This is a pharmacology study. So the goal of the study was to evaluate whether selecting antiplatelet therapy on the basis of patient genetic and clinical characteristics could lead to better clinical outcomes. So there were two groups of patients which were assigned to the standard care group or for pharmacogenetic arm, and the study was prematurely stopped because the primary endpoint occurred in less cases in the pharmacogenetic arm compared with the standard care arm. Here are the results. But despite that, the data is still conflicting, and the recommendations is still conflicting. The only recommendation is the clinical pharmacogenetic guidelines recommend using CYP2 719 test, pharmacogenetic test for patients who receive prasugrel or ticagrelor. And cardiology guidelines, ACC and HA guidelines do not recommend routine CYP2 719 C19 genetic testing. So as for aspirin, it was a highly discussed topic at the beginning of 2000 when different research groups showed quite high level of aspirin non-response. As you could see on the top of the slide, up to 30% of the patients, according to that studies, could have inadequate response. But when we use COX-1 specific methods based on the arachidonic acid as an inductor, so we see that there is a very, very low level of aspirin resistance. So that's why today it is not recommended to perform routine PFT testing in patients who receive aspirin monotherapy. But there could be quite significant function, platelet function variability, which depends on the way of aspirin administration. I want to show you one quite elegant study. So there are two arms here. The first group of patients who received intravenous injection of aspirin, and you see a very good response, platelet function response to aspirin therapy. And at the bottom of the slide, there's a big response variability in those group of patients who received different forms of oral aspirin therapy. So, and this is so-called the bioavailability problem. And it was clearly shown in one of the studies. This is the Deepak Bhatt and Anjalila work, which was published a few years ago in JACC. And it was, so the goal of the study was to determine if oral bioavailability could mediate non-responsiveness. And a high proportion of patients treated with enteric-coated aspirin failed to achieve complete inhibition of thromboxane generation due to incomplete absorption. So it doesn't mean that we need to make a routine platelet function testing for aspirin, but it means that we could have some problems, but these platelet function problems with aspirin monotherapy, but it would be linked with the problem of bioavailability. And now we are moving to the platelet function in platelet function testing in dual antiplatelet therapy, and I want to demonstrate you the original scheme, which was developed by our group, and it shows the scope of the problems in dual antiplatelet therapy and the possible ways of how we could resolve these problems. So we use ticagrelor and prasugrel in patients with STEMI and patients non-STEMI, but we still have big place for the clopidogrel usage in different conditions in patients with after elective cardiac interventions, in patients who receive oral anticoagulation therapy together with DAPT, patients with high bleeding risk, patients who have ticagrelor or prasugrel intolerance, and for some other reasons. So, and we could go by standard approach according to the current guidelines. And the current guidelines, they're mainly based on the clinical phenotype of the patient. And of course, despite the fact that we give all the recommended therapy, we will get in touch with some residual risk of bleeding or ischemic risk. I had some problems with my mouse. And this is the standard approach. And we have some two alternative ways. The first one is related with use of ticagrelor and prasugrel. When we use ticagrelor and prasugrel, in some cases, we could get in touch with so-called the phenomena of low on-treatment platelet reactivity, which is associated with the increased risk of bleeding. And we could try to overcome this risk. This strategy is so-called de-escalation strategy. I will show you some slides in a few minutes. But I want to say now that today we have 2B class indication for de-escalation in the current guidelines. So what does it mean? It means that in some cases we could go from we could start from more potent ticagrelor and prasugrel in patients with NSTEMI and STEMI, and then to switch patients to less potent drug in order to get rid of bleeding risk. But we still have a lot of problems with the escalation strategy. So we have huge amount of patients, and I also show you the slides, who still need to receive clopidogrel, and there is no other way for them, only clopidogrel. And we know today that some of the patients who receive clopidogrel could have high on-treatment platelet reactivity, which is associated with this ischemic risk. And we have the way to overcome this risk is to escalate the therapy. But we still, as I said before, have a lot of conflicting data and a lot of problems in escalation strategy. So let's start from bleeding risks. So we know from the huge trials, from the Triton trial, from Plato trial, that more potent drugs like ticagrelor and prasugrel, so the usage of these drugs are linked to the increased risk of bleeding compared with those patients who receive clopidogrel. We have a lot of data published already, which shows that low on-treatment platelet reactivity is linked with high levels of in-hospital and out-hospital major and minor bleedings. And for the last decade, we tried to follow the concept that the more intensified platelet inhibition leads to less MACEs, to less major adverse cardiac events. And this concept came from the results of the big trials of the Triton trial, from Plato trial, which showed that the more intensified therapy we give to a patient, the less MACEs we have. But please look at the results of the sub-analysis of a Triton trial, and you could see that there is a big difference in bleeding rate in the acute and chronic phase of treatment of cases, bleeding events in the chronic phase compared with the acute phase. And we also must pay attention that the most stent thrombosis events happens at the first 30 days after stent implantation. And de-escalation approach was tested in TOPIC trial, and the guided de-escalation based on platelet function testing was proved in tropical ACS study, and it was shown that the de-escalation from prasugrel to clopidogrel in the first weeks after ACS is non-inferior standard approach in terms of primary endpoints, in terms of CVD-MI stroke, and it leads to less bleedings. So, and as I said before, it is stated now in the guidelines. Now about escalation. So the first question we need to answer before we start to talk about escalation: is there any association between high on-treatment platelet reactivity and major adverse cardiac events? And I want to show you the results of the big meta-analysis, which was conducted by Daniel a decade ago, and it was shown that there is a strong association between high on-treatment platelet reactivity in patients who receive clopidogrel and thrombotic events. And also, this is also quite old study, but it's quite big. It's a popular study with the more than 1,000 patients randomized. And this study showed us that actually, no matter what kind of laboratory method you use, it will help you to give a prognosis. It will help you to show the patients who are at risk of ischemic events. So there were three methods here. It's LTA with ADP inductor. It's platelet works and verify now system. So, and if we realize that the platelet function testing could help us to predict the outcomes, then the main question is how to guide the therapy using the platelet function testing, or in other ways, how to make a patient be in therapeutic window when he use P2Y12 inhibitors. There are a lot of trials published today, positive trials with positive results. I will show you just few of them. One really nice and elegant trials. I like this trial. It was also conducted by Daniel already. And there were three arms here. It was patients after ACS, and there were a group of patients who had inadequate response to clopidogrel therapy, and they were switched to prasugrel therapy. So it was the escalation strategy, and it was shown that the mortality and stent thrombosis rate in this group of patients was comparable with those patients who have good response to clopidogrel therapy. And it was also shown that if you try to escalate therapy, not by switching from less potent drug to more potent drug, but to increase the dose of clopidogrel, it didn't give you any result. Also, one more trial. It's Sila Matula trial, also the escalation strategy trial. Some of the patients with HTPR who was switched to more potent prasugrel, and it was shown that the personalized treatment group had less CV events than those who were randomized in the standard care group. From my point of view, I think that in nearly future, we will not receive enough data to support the escalation strategy. Why? Because today stents and intervention technologies becomes better and better, and stent thrombosis rate becomes lower and lower, and it means that that we need to conduct really huge trial to get enough endpoint rate to prove the escalation concept. But despite this conflicting data, and despite the fact that there is no indication for platelet function testing in current guidelines, I want to tell you that in some hospitals in Russia, we perform platelet function guided. So we perform the platelet function guided strategy for our patients, and we do it in Central Clinical Hospital as well. And I want to show you the results of the fundamental trial, which was performed by our group in our hospital, and it was published just a month ago. We decided to prove the escalation concept not by looking only at the clinical endpoint results, but looking inside the vessel using high-resolution electronic microscopy. So it was quite big, 750 patients ACS study. So the patients were divided in different groups. It was standard care arm groups and different arms of escalation strategies. And please look at these pictures on the right hand of the slide. So at the top, this is the healthy volunteers, and you see the platelets. So they are normal in shape and they're normal in size, and there is no interaction between platelets and other blood cells, between leukocytes, between red blood cells. So now please look at the middle part of the slide. So this is the patients with ACS who received clopidogrel, and they respond to clopidogrel according to the platelet function testing. And on the right-hand side is the patient who didn't respond to the clopidogrel therapy according to the LTA and Verify Now. And what we see the thing which is impossible to see when we assess only clinical data. So we see the spontaneous aggregates, and we see the interaction between between platelets and other cells. So it's so-called leukocyte platelet aggregates and red blood cells platelet aggregates. One more thing which was found only in patients who was resistant to clopidogrel therapy, it's so-called NETs. There were no NETs in patients who had adequate response, only in inadequate response patients. So the NETs, it's a neutrophil extracellular traps. So it forms after neutrophil apoptosis, after neutrophil degradation, and there are some works today which shows that NETs could play some role in thrombotic process, and also we know today that NETs becomes a sort of platform base for the inflammation cascade. So we found these NETs in patients with inadequate response to clopidogrel. So, and what about the escalation concept? So this is the patient who is had high on treatment platelet reactivity according to LTA and Verify Now. So you see big platelets, you see spontaneous aggregates, and you see interaction between leukocytes and red blood cells. And this is the same patient after the guided escalation strategy. So this patient was switched to ticagrelor therapy. So, and you see normal platelets, normal in size, normal in shape, and no no blood cell interaction. So, and this fundamental concept was proved by the clinical results. So it was found that there was significantly low rate of MACE, and MACE it's a net adverse cardiac and bleeding events in those group of patients who received escalation personalized strategy compare with patients from the standard group. Now, one more place for platelet function testing. From our point of view, it's the patients who receive different generic agents. So, as I said before, despite the fact that in the current ACS guidelines, the drug of choice is the more potent ticagrelor and prasugrel, I want to show you the P2Y12 inhibitors administration rate in Russia in 2019 and 2020. And as you could see here, the majority of patients today in Russia still receive clopidogrel. It's 550,000 patients compared with only 45,000 and 1,000 patients who receive ticagrelor and prasugrel. And the problem, of course, is that today we have generic agents to clopidogrel and no generic agents for ticagrelor and prasugrel yet. And of course, we know today that if we increase the price of the drug, of course, we'll get in touch with the adherence problem. But unfortunately, we still have, not only in low-income countries, but in well-developed countries, we have problem with the quality of the generic drugs. And I want to show you the results of the study, which was made by our group together with our American colleagues, and it was published 2 years ago in European Heart Journal in Cardiovascular Pharmacotherapy. So it was the analysis of the FDA affairs data. So what is FDA affairs? It's a huge database which collect all information about adverse events and serious adverse events of the drugs which is already available on the market. So we collected more than 100,000 patients who received clopidogrel in US market. And we divided them into two groups. So one group of patients received brand clopidogrel and other group genetic clopidogrel. So, and it was, so we found and we showed that there is some problems in terms of the efficacy of generic clopidogrel. So more thrombotic and cardiac events happened in generic clopidogrel group compared with the branded clopidogrel. And of course, this is the problem from our point of view, the problem of the quality of the generic drugs. And I think if such kind of study is conducted in some low-income countries or developing countries, the problem will be even more bigger because as I know, there's big problems with the quality control of quality of generic drugs, which comes to the regional markets. And at the end of my presentation, I also want to share with you the results of one of our trials, which was published last year in the European Cardiology Review. This is the results of cost effectiveness of platelet function guided strategy with clopidogrel and ticagrelor. So this is the mathematics study which showed that if we start our therapy of ACS patients from clopidogrel and test the patient using verify now P2Y12 inhibitor assay and continue using clopidogrel if patient have adequate response to clopidogrel by using high quality generic clopidogrel, and we switch the patient to more potent ticagrelor only in case if a patient has inadequate response to clopidogrel. This approach is significantly more cost effective than this the standard approach, which is stated in the current guidelines when we use ticagrelor, or for example prasugrel. Here in the study was ticagrelor for the whole period for the 12 months. So thank you very much for your attention.